All right. Thank you so much, ma'am, for the opportunity. So one of the things which I was told is to defend the multifocal IOL in unilateral cataract. And so basically, if you have a scenario like this where you have unilateral cataract, and the question comes, what IOL do I implant in these cases? To answer this, it's very simple. By answering series of questions. First and foremost is, does the patient want spectacle independence most of the time? It's a simple question. And the answer also is pretty simple. Obviously, everyone would want a spectacle independence most of the time. That is, if the money is not a factor. Now, the next thing is, let's look at the literature, what actually is there in already published. So this is one of a wonderful paper published in the American Journal of Ophthalmology. Basically, they divided the unilateral cataract patients into 4 groups. The first group was where the patient was implanted a monofocal IOL. Second group was implanted accommodative IOL. Third group, diffractive multifocal IOL. And the fourth group was a refractive multifocal IOL. So when you look at the results, group 3 and 4 had higher patient satisfaction, almost about 92%, had better spectacle independence, better stereopsis, satisfactory visual, functional vision at all distances, as compared to group 1 and 2, which did not do that well. And here also, obviously, when you look at the visual acuity, definitely they do much better bilaterally in terms of, near vision, and the distance obviously is good. So the conclusion of this particular study is the unilateral implantation of multifocal IOL provides the patient with a broader range of functional vision from near to distance foci and high rates of spectacle independence and better stereopsis. And to keep in mind is, this is the older generation of multifocal. It is not even the trifocal IOL, which we are talking about, which is performs so much more better, has so much more less side effects as compared to a multifocal IOL. And obviously, there's one more study in the JS series where it's shown that, unilateral multifocal phakic patients with good functional near vision and intermediate vision and far distances, regardless of whether the phakic fellow eye is myopic, hyperopic, or ametropic. It's a very clear, a very distinct conclusion which the study has shown. There are several other papers, but the question is now we know what the patient wants. And second is, we know what that it is if at all you do any unilateral multifocal IOL implantation, patient does well. But the question is, now we have so many series of presbyopic IOLs. Really, we are in a dilemma of how to choose. So if the patient wants a presbyopic IOL, we are left with this huge array of options in the market, and really forget about the patient. The doctor itself is confused on how do we actually counsel all of this different options to the patient. To make it very simple, what I follow is just categorize into diffractive and refractive IOLs, basically refractive presbyopic IOLs. And then how does your decision making happen? So how do you choose a diffractive or a refractive IOL? Is, let's say, if a patient wants a presbyopic option, then you have to look for the diffractive IOL suitability criteria. That is, I think it's a pretty standard. First and foremost, the patient should be motivated. Most of the eye should be normal, and the rest of the scenarios. And if at all the patient is suitable for a diffractive IOL, and the patient is not a very type A personality, very high demanding patient, a very normal, has more realistic expectation, then you go ahead with the diffractive IOL. Now, if a patient is more of a type A personality, very unrealistic expectation, then simply go with a non-diffractive IOL like the VVT. And obviously, if they're not suitable for a diffractive IOL, then you go with the refractive or a non-diffractive IOL. So to conclude, what to do in a unilateral cataract, the answer is you can have a trifocal IOL as an option, provided the different scenarios and suitability criteria. If the patient is suitable, then definitely is one of a good option which the patient will be very happy with. Thank you for your time.
Thanks, Dr. Naren. That was nice. Dr. Minu, could we have your expert view?
Yeah, thank you, Dr. Chitra, for this opportunity, and well discussed, my young debaters. A lot of it has been told, but both of them have been very modest in telling that the patient comes first. and it is not we who are choosing, or we are telling that this is the option for you. So that is, I think, the most crucial part, because after getting this topic, a lady whom I had placed a multifocal, she was adamant on having no near vision glasses, but had only one eye cataract. That was around 8-9 years back. And then still she doesn't have cataract in the other eye. And still she came 2-3 weeks back, and then she was given glasses by somebody recently. And she said, "Do I need to wear this, doctor?" I said, "Do you want to wear?" She said, "No, I can see everything. I can read, I can see distance, but they gave me this for using. Should I use?" So the question is whether this patient's mindset has changed over time, or somebody has given her something or asked them to do something. So these are very important factors. We know that theoretically everything exists. Monofocal has its advantages, trifocal has it. But then if the patient is another patient came yesterday, wife of a bilateral multifocal patient. That was multifocal before our trifocals. He is still going around without, even after a yak capsulotomy, without near vision glass. She is unilateral cataract. She came and told me, "I want only that lens. Whatever it is, I want only that husband's lens." So it is the experience of the patient and what their mindset is. If they're not motivated, or they are happy about what others are having with this kind of lenses, then if you push them, it is not going to work in many patients, because this neural adaptation thing comes last, because we have to investigate extensively, because we have seen in the previous talks in corneal part of it, the investigation part on cornea and the effective lens position and the centration and the macular issues have advanced so much that we are able to screen out more patients who, although they opt for multifocals or trifocals, are not good candidates for trifocals. So once we weed out so many the unidentified problems which are there before, and we are branding them as a adaptation issue, has come down much. So the neural adaptation happens as a last part of it, but still it's there. It's there. I agree. So monofocal, I try to tell patient that these are some of the things which you will have to expect in a multifocal, although you may most of the time have no glasses for near vision. But the other eye refraction, even this lady which I'm talking about, she has developed a 1.25 cylinder over the last 6, 8, 9 years. Still, she has 6-9 parts vision and she doesn't want to wear glasses. So, although somebody gave her glasses, and her near vision was only N8, but she's happy with that N8, and she says, "I can read everything." So again, it depends. All depends on how a patient expect things, and we know that we should know the background of how a VVT is going to function, how an EYEHANS will function, and we should tell them clearly that this is going to happen. And it depends on the age, but I am not touching on the pediatric part, which is controversial, but then I would not place a multifocal on a pediatric cataract where everything is dynamically changing over a period of time, and it's very crucial to correct the visual axis or the optical axis very effectively during that developmental period. But the adult part of it, I feel that if a patient is understanding regarding his own other eye, whatever, even if other eye, whatever the refraction is, we know from their study and we know from patients that if you give trifocal and they're happy with that eye and they don't consider the other eye at all. But there are some people who are telling that even though this eye is clear, the other eye is bothering me, and so I will definitely wear glasses. Anyway, I have to wear glasses for the other eye. I feel binocularly it should be good. Driving, it should be good. I should see with both eyes. So it depends on the mindset, the type of patient, the activities of the patient, and then we choose the lens after telling them what both of you have talked and showed very elegantly, that these are the pros and cons of these kind of lenses. Thank you very much.
Thank you, Dr. Minu. Thanks for your thoughts.
Thank you.
Dr. Saurabh, would you think of going in for doing a clear lens extraction if the other eye has no cataract in these patients? They never brought that up. What are your thoughts?
Yeah, if the other eye has significant refractive error, then that is a very good option. Yeah. And one thing I just wanted to add in the discussion in this unilateral cataract, one thing I make sure that I talk with this patient personally and tell them not to compare the two eyes after the surgery. Because I tell them that if the other eye is either emmetrope or it's a natural clear lens, the clarity will be always better than the operated eye in most of the cases, though EDOFs generally match the unoperated eye, but trifocal definitely they will reduce the contrast. So those patients who keep comparing the two eyes are the most unhappy patients. So you have to inform them beforehand that they will not be same. The vision will not be same in two eyes. If you are okay with that, we can go ahead with the surgery.
Thank you,